Welcome, everyone. This is our very first North American Society of Interventional Thyroidology webinar on case studies in RFA. And we're really glad that you all joined us. My co-moderator this evening is Ralph Tufano, and we have three excellent panelists featuring Dr. Baek from Seoul and Asan Medical Center, and Steve Hodak from NYU, and Tim Huber from OHSU. So welcome, everyone. This is really for those who are know that they're interested in RFA and they really are ready to start thinking about cases and how to really do the cases. And it's going to be mainly a case-based discussion. So we encourage questions in the chat function. If you click on the chat button at the bottom of your screen, please make sure that you direct all the questions and comments to panelists and attendees. You may have to make that switch on your own screen, and just ask any questions that you may have. Okay, let's get started. If I can get it. We do have a few financial disclosures from our panelists. And again, just to kind of reiterate the objectives of this particular forum, it's really to encourage a discussion, not more broad-based ideas or concepts, but really kind of getting into the nuances of how you think about these cases, how you plan to do these cases when you're ready to do them. So Ralph, do you want to do the first case?
Great, Jen. Thank you very much. I hope everybody can see me. Really welcome to everybody who's joining us. Special thank you to Professor Baek for being here and being a mentor for all of us and a pioneer in this area. And thank you to our panelists, Dr. Hodak, who is an endocrinologist, Dr. Huber, who's an interventional radiologist. You notice we don't have any surgeons on the panel, even though we're moderating this session. So we'll try to keep surgery possibly in the loop somehow, some way, maybe throw a curveball here or there, maybe, I don't know. But I want to also give a special thank you to Steve because he was very helpful in our ATA, the American Thyroid Association Directed Interventions course, and he's been very kind to share his slides, which he utilized for that course. So Steve, thank you for facilitating this effort. As always, you always a great help. So this is the first case we're gonna do. And it's interesting that we label it as a cosmetically bothersome nodule. This is a 66-year-old woman who's had a thyroid nodule for quite a while. She really thinks it's unsightly, especially as you can see when she swallows, you can see that movement and it's irritating to her, but it really doesn't bother her symptomatically otherwise. She's had 2 fine needle aspiration biopsies that have resulted as benign cytologically and normal thyroid function. The ultrasound appearance completely consistent with a benign thyroid nodule and no risk factors for thyroid cancer. So Steve, since this is your patient, is this an appropriate case for RFA? Do you think that this is a case that maybe one should be thinking about even as a first case?
Yeah, great. So great question, Ralph. I mean, it's sort of a softball because this is sort of the ideal case for radiofrequency ablation. This is an otherwise healthy patient with a minimally symptomatic nodule, whether it's cosmetically symptomatic or if it even had some compressive or obstructive symptoms, it would still be a very reasonable target for radiofrequency ablation. I think the important things are ensuring that the nodule is low risk, and typically a benign biopsy ×2 is adequate for doing that. The ultrasonographic appearance, of course, is important. But to answer the second part of your question about is it a good first case, I think that could be the case, assuming the operator is adequately trained and comfortable with the procedure. And the point that I would make repeatedly is that this procedure is simple, but it's not easy. It looks very straightforward, but execution is really critical. And it takes a surprising amount of practice, even for good operators, to achieve good proficiency. So I would just advise everybody to not underestimate the amount of preparation that's needed to do your first case.
Yeah, thank you, Steve. Jen, can you do an advance, and I think we have an ultrasound as well that shows the nodule in a transverse view so that everybody can appreciate the echogenicity and the sonographic features of the nodule. So I think everybody would agree that this is a benign nodule. Dr. Baek, can you tell me what are the critical components of your ultrasound evaluation when you're thinking about strategically a plan to do RFA? Is it just adequate to have a transverse and sagittal view? Do you use Doppler to help you get an appreciation for how you're going to target and strategically treat this nodule? Can you give us a little bit of what the essential findings on ultrasound are that you need to have to help plan your procedure and be successful?
Hello everyone, my name is Dr. Baek from Seoul, Korea. In my opinion, this case is wonderful to recommend for beginners. So when I plan thyroid RF population, the first one is location. I would say location is the most important thing. I mean, if thyroid nodule is totally inside the thyroid gland, it would be better. Then exopedic nodule, especially inferiorly, is very difficult to treat completely at one session. So this nodule shows nearly surrounded by thyroid gland, and size is acceptable to treat. The other thing is vascularity. I always check the vascularity because, as you know, we treat the nodule using vascular ablation technique. It is very effective to control vascular thyroid nodule. If thyroid nodule is not vascular, you don't need to use vascular ablation technique. So I would say location and vascularity is very important.
Yes, thank you, Dr. Baek, for letting us know that and talking about the vascularity and appreciation. Can you tell us specifically, though, because I think even though it's a little bit of an advanced technique for some, this vascular ablation, what do you do differently if a nodule has a significant amount of vascularity, as you were saying? And what is your concern if you don't treat those vessels?
Yes, that's very important. I mean the vessel, the feeding vessel. I first screening the feeding vessel. Where is the feeding vessel? So right. I first target the feeding vessel, especially in isthmic area. I would like to stress the vessels in isthmic area should be managed first because we use a transisthmic approach method. So we can treat the vessel by somewhat higher energy, RF power, I mean, and we need to give enough lidocaine around isthmic area. It's a tip of vascular ablation technique.
Yeah, that's excellent. Thank you very much for highlighting that. I think that's incredibly important. And so keep that in mind when you're doing your assessment. The Doppler is very helpful to assess vascularity, especially along the isthmus region to treat those vessels and the feeding vessels. Otherwise, you're more likely to have regrowth and the problem recur. So Tim, can you let me know a little bit about your practice, and when in the United States, since it's a sort of nascent intervention or technology for us, if you, especially during times of COVID, have patients who want to do telehealth, do you feel that that's an adequate screening for these patients to consider doing RFA? If you're given static images, do you feel that you need to do your own ultrasound? Can you give us some background on that? Because certainly there's very few physicians or providers really doing RFA in the United States. So we often encounter patients who are giving us, who want a telehealth appointment and asking, am I a candidate for this?
Yeah, great question. So we have a unique practice out here in the Northwest, in that we have a very large catchment area. So we're getting referred patients not just from Oregon, but from Washington, Southern Alaska, sometimes the Mountain West. So we see people from all over. Many of them are many hours away, and they're very interested in the option of a telehealth visit. I think it can be appropriate, but I think you need to be fairly choosy in which patients you allow to do telehealth. I think a lot of the information that you need to get to screen a patient, you can get either from the ultrasound and from the labs that can be done locally. And so for some patients, we allow that as adequate, with the understanding that if they come in to see us to have a procedure and we find any red flags, we may need to reevaluate or change tack a little bit in the middle of things. But for the most part, I think you can screen the ultrasound images if they're good enough quality, and the nodule seems like it's an appropriate position. It's not too low, like Dr. Baek was saying. I think you can do a little bit of an initial screen to find patients that would be reasonable. And you can do the telehealth visit. You can often do a physical exam virtually with a lot of these patients, and that can oftentimes be adequate. Now, for some patients, it won't be as adequate. They might have a lower nodule that kind of extends down below the clavicle. It might be well visualized on ultrasound. And in that case, you'll probably want to bring them into your clinic and scan them yourself, do a physical exam, and just make sure that you're not missing something. Great procedure.
Yeah, thank you very much. Steve, how do you counsel a patient for RFA, especially since it's early in many of our experiences, right? So what do you tell this patient, and how do you set realistic expectations for the both of you?
Right. So I think it's important for anyone who's getting started, or even for people who've been doing this for some time, until you have really kind of an unimpeachable track record. I think it's important to be transparent with your patients about how many cases you've done, what your experience has been. And everybody has to start with a first case. So, I would disclose that also when you're signing your first patient up. I think that if the procedure is done correctly in appropriately selected nodules, it's extremely safe. It's very effective. I think there can be misadventures with RFA, like any sort of procedure, and it's important to disclose the potential complications to the patient. I make a point of telling them that the whole concept of RFA is that anything that is touching that needle tip when I activate the needle is going to be destroyed. So it's my job to make sure that the needle is kept under continuous visual guidance, and that I'm activating it only in the places that I want to treat. And if I make an error, I can hurt the patient. So my goal is to be as controlled and as thoughtful about the way I proceed as possible. I think initially, as one is getting started, and then later based on one's actual experience, you can give the patient some idea of what to expect. It's important to tell people that in some cases, you may not be able to effectively treat a nodule. I think those are few and become fewer as you become more expert in the technique. I think many of us are seeing the kinds of results that we've read about in the literature, where we're seeing fairly immediate symptomatic improvement within a week or two after a successful procedure, something on the order of 50 to 60% size reduction in typical solid nodules within 6 months of treatment. And then, for the cases, the relatively fewer cases that all of us have had at over a year, we're seeing results in the 80 to 90% size reduction range. Well, I think we'll talk about toxic nodules later, but that's another excellent application of this technique, and restoration
we
of
will.
thyroidism is another important thing that you can offer patients. But I think being as transparent as possible is really the goal.
Sure. Perfect. Let's move to the next slide. Jen, would you please do that? So this is the initial result that you achieved, and you had a 58.8% volume reduction. There's the sonographic features of the nodule comparing the two pre and post. And so, Steve, just let me know a little bit about your technique. Is this in the office with just straight lidocaine, or how did you do this, and what do you usually use as your technique? Is it in the clinic with just lidocaine alone? Let us all know that.
Right. So I of course, like many of those on the call, I learned from Dr. Baek and also from reading the literature. So I use an initial subcutaneous wheel of typically 1 or 2% lidocaine. I don't find that it makes a lot of difference. And then we'll infiltrate lidocaine along the thyroid capsule between the sternothyroid muscle and the thyroid gland. If you can get the needle into that virtual space and start to inject lidocaine, you'll see very nice hydrodissection across those tissue planes. That lidocaine will then diffuse over the surface, the anterior capsule of the thyroid, and gives extremely effective numbing of the terminal branches of the cervical innervation there. That is the pain sensitivity for the thyroid. And I think Dr. Baek, he can speak to this directly. I think he uses an empiric dose of 10 milliliters of lidocaine, and I'm not sure if he uses 1% or 2%. I think we all do it without epinephrine. But what I do is I usually calculate, based on the patient's age, their renal function, and their weight, what the maximum allowable dose of lidocaine is for a case. And I will use an appropriate amount that makes me feel that I'm getting a good plane of anesthesia, up to but not exceeding that dose. Once I have the patient anesthetized, I use the fairly traditional moving shot transismic approach. I would love to hear Dr. Baek talk a little bit about how he conceptualizes the treatment of a nodule like this, whether his intention is to closely overlie the needle tracks, or does he find that if he inserts the needle and creates a needle track as he's pulling the needle back, he can then leave some normal thyroid tissue in between his next needle insertion and cut down on the number of times that he needs to insert that needle into the nodule?
So great question. Let me just highlight a few things, because we only have a few more minutes for this particular case. One very important point you already said: if you can see the needle, yes, you need to see it all the time in the needle tip before you turn it on. That is critical. And that is what you need to do to be as safe as possible. The second is, you talked about symptoms, even the cosmetic score improving way before the significant volume reduction. And I think that's what we've all experienced a little bit. What I would like to ask Dr. Baek then to comment on is, how much is enough? Do we need to be very, very, very dedicated to ablating every single area of the parenchyma of this nodule? Or, as you had just said before, is there a technique where, we can create that injury parallel along that track as we're coming back as well? So how do we do that? And then how much power, how many joules, is that all important? I know that's a little bit more advanced, but just the general concept, Dr. Baek, can you please let us know about the moving shot technique and how much do we have to ablate?
Yes, that's important. In terms of electrode tip and power, I usually use 1 centimeter active tip with 50 watt of RF power. So if it is not work immediately, I increase the RF power, and I treat as much as possible at first session, as much as possible, and then wait. If on the treated area does not grow, I leave it. However, if untreated area start to grow, I plan second ablation.
And
So,
this is very, yes, go ahead.
Yeah, thank you. So I recommend more than 90% at first session.
And this is an important discussion to have with the patient. How often are you following these patients up, Dr. Baek?
It depends on the completeness of ablation. If nodule is nearly completely treated, first visit would be 6 months. If not, first follow-up would be 1 or 2 months to decide the second ablation.
Fantastic. I think that please, I would encourage everybody, use the chat function. There'll be many questions. We can't get to all of these questions right now. We'll also try to get back to you by email if you have more questions. And so we're going to move on to the second case, and Jen's going to take that over and ask appropriate questions regarding it. Thank you.
All right, so our second case is a really, really large thyroid nodule. A healthy 39-year-old woman who has a long-standing thyroid nodule that's really only been mildly symptomatic in the past. She reports occasional choking with both liquids and solids, but has a globus sensation that is positional. She has trouble breathing or when she's lying down flat. She can't wear turtlenecks and tight collars because she feels like there's a band around her neck. And she's noticed that the symptoms have slowly worsened over the past 12 months. So first question to Dr. Baek, what really counts as a large thyroid nodule where we have to start thinking about additional ways of approaching it?
Thank you for your question. Large nodule is still challenge for me, and this is really large nodule. So as I introduced, in case of large nodule, especially more than 4 centimeter, my first ablation should be as much as possible. In case of less than 4 centimeter, 90% of ablation is possible at one session, but more than 4 centimeter, it depends on the size, location, and the tolerance of a patient, vascularity, some factors are involved.
Thank you. Yeah, that's large nodules are really difficult, I think, that we're all learning here in the US. So Tim, you got this lady that comes in now. How do you look at the nodule differently? Is your physical exam any different? Are you looking at different things on ultrasound as you're planning out how you're going to ablate this nodule?
Great question. So, ultrasound, for these larger nodules, I really like to do my own ultrasounds in clinic. And I think it's important to get a good sense in your head of the size and extent of the nodule. They can have very different morphologies. Oftentimes, these larger nodules, I find that I'm seeing hang down into the upper part of the thoracic cavity, kind of down behind the clavicle. Sometimes you can improve that with extending the neck and kind of get it to pull up a little bit higher into the neck so you can visualize the whole nodule, but sometimes you can't. And there's just a sort of substernal or lower extent that you just can't fully appreciate. That I find is really important to talk to the patient about and explain that that's more likely to require a staged approach. Like Dr. Baek said, we always want to get as much treated in one session as we can, and we shoot for 90% or more if we can. But for those where you can't visualize the full extent of these large nodules well, I think it's important to tell the patient that you're probably going to undertreat on the first session. And you'll have to come back most likely for a second or a third treatment. So that colors my conversation with the patient for sure.
And Steve, when is it too large? Do you ever talk to these patients, go, I think it's better for that you see my partner Kapil Patel for an operation? What makes what goes into that conversation?
Yeah, I think really the bottom line for too large is if you cannot adequately visualize it with the ultrasound, you're not going to be able to access it with the transducer, and you're not going to be able to keep your transducer visible while you're treating. That was sort of my original definition of too large. You know, if I couldn't see it well enough, then I couldn't treat it, and so then it was too large. Michael Dweck, I'm not sure if he's on the call from UCLA, actually has suggested in a couple of meetings that you can take nodules that extend very far inferiorly, even well below the clavicle, and intentionally plan to treat nodules like that in a multi-step ablation, where you're initially treating the more cranial parts of the nodule, the intent being that after treatment, those areas will involute, atrophy, and shrink, and then the more inferior parts of the nodule will rise superiorly, and then in a separate procedure become more easily accessible. So I think really the question is what's too large for a single episode of RFA? And kind of if you can see it and you can access it safely, I think you can treat it, and nodules can be quite large in that case. This particular nodule in this case was nearly 7 centimeters in its length. And as we'll see, I think I did treat it in one session. And it was a long case, but we got a very good result. So, that's surprisingly large, but you can still treat it. It just depends on where the nodule is located.
Tim, do you do anything different in terms of pain management for these much larger nodules that are going to take a longer time to ablate?
So for our sort of pain management protocol here, we've started giving patients Tylenol pre-procedure. And that seems to actually help a lot post-procedure with their pain as well. And then we've had much better toleration of the procedure with that. We've also started using Marcaine in addition to lidocaine. So we'll do the initial parathyroidal injection of lidocaine, but also give some Marcaine, usually kind of split it between the pre and then post. And having that little extra to give throughout the case, it seems to help patients tolerate these longer procedures. You want to be prepared for a longer procedure with these, 5, 6, 7 centimeter nodules, because it's going to take longer, as I'm sure Steve will tell us. Those are kind of two things that we're doing in our practice that seems to help patients tolerate these longer procedures. Sometimes their anxiety or their neck pain or discomfort can be the biggest limiting factor for you.
And Dr. Baek, you can see here there's a post 1 month RFA ultrasound. How do you think about these large nodules in terms of assessing for problematic areas of regrowth on your follow-up? And when do you address them?
Excellent result. The scale, who treated this one? The scale is better than me. And
Dr. Hodak.
Hodak, Steve, wonderful. Huh? You are better than me. In my opinion, considering the large size of the nodule, the result is amazing. Very, very nice result. So the Doppler would be important. If there is remained vessels, we treat as much as possible the nodule, and the second session will be shorter. I mean, the vascularity is very important to decide the second ablation. So is there any Doppler ultrasound imaging? No?
I didn't show the Doppler ultrasound images, but there was, so that you're asking, of course, the right question. Inferiorly on this post-treatment on the right, the 1 month post-treatment, you can see that little black line that's sort of right above the 3.1 centimeter title. Yeah. That's a vessel. And if you look at 9 o'clock on this nodule, just below the 47.2 millimeter mark, you can see there's a little bit of untreated tissue there. So I think, full disclosure, I think I got a very good result from this nodule. We'll see if it regrows over time or if it requires a second treatment. But thank you for the compliment. This nodule was not vascular in the treated areas after the treatment.
And anyway, very excellent.
I had a good teacher.
So Tim, we see that the nodule looks quite different from the pre to post ablation ultrasound pictures. Since you have such a huge catchment area, I assume that you're not having everyone fly into Portland for your follow-up ultrasound. So what's your protocol for patients that are a little bit farther away? How do you communicate to outside radiologists that might be doing these ultrasounds and seeing a really nasty looking hypoechoic nodule? And often they're actually hard too for patients. So walk us through that counseling and your protocol for that.
Yeah, great question. So in this up here, we started a multidisciplinary group where I see the patients, but we're also discussing them with surgeons and endocrinologists as well. And so early on in this, I reached out to our radiology colleagues who do the ultrasounds and follow up for us, as well as some in the community who will be involved in that potentially, just to kind of give them a heads up on post-operative appearance, kind of what to expect on these nodules. I'm trying to educate the radiologists as well on this new thing that we're doing, because it's a little unusual. And like Jen said, they can take on a sort of worrisome appearance if you don't expect to see this. So trying to counsel everybody with some education sessions before they were going to see these patients so they wouldn't kind of raise the alarm flags too soon. Our protocol out here is we scan everybody in clinic. So they all come back to see me at 1 month post-procedure, where we do in-office ultrasound, checking for complications, checking on the voice, making sure that the symptoms are improving, hopefully, and there's some reduction in the volume. Then we do a formal ultrasound at 3 months, and that can be either done locally if they're in the area or remotely. And some of those 3-month visits I'm doing actually virtually for some patients that are farther away, since we can get the ultrasounds typically locally there with friendly radiologists that have been kind of prepped on what to expect, as well as labs for patients at 3 months who had thyroid function abnormalities ahead of time. We can talk about that a bit more in the functional nodule section. And then we're scanning in clinic, basically, in most cases, no charge at 6 and 9 months, and then another formal at 1 year. So basically every 3 months with a 1 month follow-up.
Excellent. So it's really important these patients aren't a one and done deal, unfortunately. You do have to keep tabs on them for a while to ensure the success of the ablation. So Steve, you mentioned that you're going to wait and see on this patient whether or not she's going to need a second ablation. How do you set the expectations with patients in terms of how much volume reduction they can expect to have with these larger nodules, and do you aim to actually achieve the 80 to 90% threshold that we usually see with single sessions, or do you have different criteria for this group?
Yeah, that's obviously the critical question. I think, as Dr. Baek was saying earlier, my goal, I think all of our goal when we're treating these nodules is to completely destroy the nodule. And I think in theory, if you can completely and thoroughly treat a nodule, the nodule should be completely destroyed and you should get a maximal reduction in size and a maximal outcome. It's pretty clear from the literature, and I think from everybody would agree with this from their experience, larger nodules are harder to treat, and you often fail because it is just a much more ungainly target. So I would counsel a patient that my goal is to give them maximal size reduction, restoration of euthyroidism if they're thyroid toxic, but my intent is to definitively treat the entire nodule. I will tell people that larger nodules are harder to treat, and there's a higher likelihood that my treatment may be incomplete, though I will try as hard as I can to thoroughly treat it. I think large nodules, if you can treat them through their entire volume, you'll get just as good an outcome as you will for smaller nodules. but that's often easier said than done. And I think that's the point.
So if you at 12 months, you get 65% VRR, and the nodule is now 3 centimeters in size. Do you leave it alone, or you try to get it smaller?
Yeah, so this was a cytologically benign cosmetic nodule that was causing some symptoms that she didn't like. If the cosmetics are improved, if her symptoms have resolved, if the volume reduction decreased steadily and then plateaued, I might be tempted to just keep that nodule under observation and only treat her again if it starts to enlarge or if her symptoms come back. If the nodule decreased in size, but then started increasing in size, I think I would take that as a sign of a more definite treatment failure and would probably want to treat that nodule or retreat that nodule sooner.
And then for any three of you guys, how consistently do you guys keep track of how much energy you are delivering during your ablation procedure? And do you aim to deliver an average amount of energy for any particular volume nodule?
So we started tracking with the StarMed equipment our energies for every case now for each nodule that we're treating. At this phase, we're mostly using it for learning and feedback for ourselves. We're trying to get a better sense of when we're noticing residual tissue left behind or treatment failure like Steve was talking about. Are we noticing in our own patients certain thresholds with joules per cc of tumor volume that kind of correspond to that? It's something we're sort of looking at for quality purposes here. So I don't have any data to tell you just yet or any thresholds, but we are starting to monitor that. And I think it's important that everyone be mindful of that and try to start tracking it as much as they can for research and for quality purposes. I think it'll become a commonly reported part of the dictation.
Dr. Baek, do you have any pearls for the rest of us in terms of knowing if we've delivered enough power for our nodule?
Yes, it's an important point. In my experience, high energy is required in solid nodule, then P-solid nodule, and vascular nodule, then less vascular nodule. So it is not clear. The absolute value is not clear.
Okay, that's really important information to look at too.
Jen,
all right.
Jen, it's Ralph. Just there was a little bit of controversy and some discussion in the chat group, maybe not controversy, but the need for more than one entry point. What the panelists think about that, especially Dr. Baek. I don't know, is this something that if you need more optimal access, angulation to try to ablate areas and you need a second entry point, is that really an issue, or do you try to persist and just use one entry point and make it work that way? Can the group comment, and especially Dr. Baek, on that?
You mean when is the proper time for second ablation?
No, I'm sorry, Dr. Baek. People have been on the chat function saying only one stick with the needle and one entry point into the skin, or with these larger nodules, would you have to use two or even more possibly?
Yes, I usually use only one electrode. And you mean the puncture point?
The puncture
point, yes.
Puncture point, yeah.
It depends on the longitudinal length of the nodule, longitudinal length. If it is long, I mean the long diameter is more than 4 centimeters, we need two or more puncture points. But if it is less than 4 centimeters, one puncture point is enough.
Excellent. Thank you very much. And I think that is the important thing here, is that if you need a second puncture point to allow for more complete ablation, why not? Because the alternative would have been something like surgery for this patient to treat this. What is really the downside of making another puncture point to get a more adequate ablation? One other question related to these larger nodules. What if this nodule is predominantly cystic? How do you manage that? Let's say it's not greater than 80% cystic, but it is certainly very cystic. Can anybody on the panel comment about technique? Would you drain the cystic part first? Would you use ethanol in combination with RFA, and RFA in particular for the solid portion? We don't always have these large, completely solid nodules.
In my opinion, there are several technical methods. I mean, the combination of ethanol or aspiration, but I prefer using RF ablation only. Usually, I do not combine ethanol, and I treat the vascularized solid portion first.
Yes.
And then aspirate in cystic area. That is technical point to minimize the rebleeding from the vascularized solid portion. Therefore, we should use a relatively small amount of electrode. I mean, the 7 millimeter or sometimes 5 millimeter small small electrode tip, because the solid portion is not so much.
Yes, yes. Great point. This is excellent, and that you know that the group now can say that we can use RFA alone in these circumstances, and in fact expect very good to excellent results. So thank you. Let's move on to this last case in the last 20 minutes or so. We'll need to finish on time. This is a solitary hyperfunctioning thyroid nodule. And so we had some questions in the chat group about this situation. This is a very healthy 40-year-old woman. She presented with moderate hyperthyroidism and a very clear-cut, autonomously functioning left thyroid lobe nodule. And you can see confirmation on the radionuclide scan. And this is important. The thyroid function was normalized on methimazole. This patient refused radioactive iodine and surgical management for one reason or another. And it is very interesting, the difference in our demographics. We see this, especially in surgery, that most of the younger women would shy away from radioactive iodine for many obvious reasons, and maybe some not so obvious, and maybe prefer surgery. But this would be a very nice happy medium if it works. So most of these nodules are benign, and I'll ask Steve right off the bat. Steve, do we need to final aspiration biopsy this nodule? You've done your ultrasound, it looks benign. You know it's autonomously functioning. I know we're starting off with RFA, but would you biopsy this otherwise? Do you need a biopsy?
Yeah, you know, Ralph, I mean, it's a good question. And I think if you want to be dogmatic about it, if you're convinced that it's a straightforward hyperfunctioning nodule, the dogma is that that is not going to be a malignant thyroid nodule. But I've certainly encountered malignant hyperfunctioning nodules. Yes. I'm sure all of you have too. FNA is such an easy, helpful, straightforward procedure. You know, you really have to twist my arm for me to not want to do an FNA. So I think doing at least one negative FNA in a nodule like this that is hyperfunctioning, I think that's adequately reassuring. I don't think you need to do it twice. I would remind people, if the nodule doesn't look like a typical archetypal hyperfunctioning nodule, I think you have to be a little bit more suspicious about that. But in this case, I would do one negative FNA, and if as long as the results are convincing, I'd proceed with RFA treatment.
So great, thank you. Any differences for the workup of these patients Steve, just, you obviously manage these patients and either submit them to surgery and have in the past, or prepare them for radioactive iodine. And now we have RFA as well. So how do you select the intervention that would be best for them? How do you help them to make that value-based decision? How do you counsel them and prepare them? Is it any different than surgery?
Well, obviously the big difference, until we have a CPT code, one of the major factors is the cost, right?
Yes.
So there's generally no third-party coverage for radiofrequency ablation, and it's not an inexpensive procedure. I think it's costing anywhere from $3,000 to $5,000, and sometimes more depending on where you're doing it. So that is sometimes a deciding factor right off the bat, that if you need definitive management, RFA may not even be accessible to some people, and then alternatives are going to be the only options you have. I think this is a discussion that you have with the patient. There are risks and benefits of each type of procedure. And I think the important thing is to just be transparent about what they are, what the advantages are, what the benefits of RF are, the benefits of surgery, the benefits of radioactive iodine, which I think is probably a third-line option in this case. But the patient has to be educated, and then I think they make the decision about what fits best for them.
Right, absolutely, agree. Dr. Baek, these are more challenging, of course, right? You're needing to achieve a functional result as far as trying to make them euthyroid, these patients. And is there a volume cutoff that you say, maybe this is not going to be as successful, I may need to do 2 treatments or more? So let us know where we should think about beginning with these. Of course, we don't want to do a very large hyperfunctioning thyroid nodule to start, but maybe a smaller one once we start thinking of treating hyperfunctioning thyroid nodules. Can you let us know, please?
Yes, a smaller one is easy to treat in hyperfunctioning thyroid nodules. And this is more than 4 centimeter thyroid nodule. And maybe it is not easy to treat at one time.
Yes.
However, we can treat a big nodule by additional RF ablation.
And Dr. Baek, please comment on vascularity, and if it was important before in some cases, how much more important is it in this type of situation with the autonomously functioning nodules?
Yes, as we know, endocrine tumors release hormone into the vessels directly. So usually endocrine tumor is hypervascular than non-functioning thyroid nodules. So vascular ablation technique is more important in hyperfunctioning thyroid nodules.
Tim, thank you, Dr. Baek. Tim, in your practice, when you see these patients, what is your strategy? How does it differ from those that have a non-functional benign nodule cytologically?
Yeah. So I think the size is a real important consideration initially when you're talking to the patients. I think Dr. Baek, his comment on smaller nodules being important to start with is really has been true for us. We've selected smaller nodules to treat initially, and the first 2 patients we've treated here, we've had very good success. Both were euthyroid by 3 months and have been able to maintain that and resolve their symptoms. So I think that picking smaller nodules for your first cases is a good way to go. That bigger volume reduction, more complete treatment is going to be much easier with those nodules. Another consideration is these tend to be hypervascular, and so there can often be a lot more heat sink. It can be a little bit more difficult to get a good treatment of the margin of these nodules. So I think some of the perivascular ablation techniques Dr. Baek was talking about can be very useful in these cases. So I use those not infrequently during these kinds of cases. But setting expectations with the patients, I think, is very important. I mentioned to patients that if they want a one and done type of treatment, surgery is the best option for that, although we'll try our hardest to make it a one and done kind of treatment with RFA.
And that's a great point. I'm glad you brought that up. As Tim, being an interventional radiologist, is very fair and includes all of the treatment options on the table for the patient to make the informed decision that they feel is best for them without bias, or at least without a lot of bias. So I think that that's excellent and a great discussion, because we really have to disclose and avoid paternalism, all the options for the patient for them to make an informed decision. The methimazole in this case was discontinued immediately post RFA. This is the Steve Hodak highlight show here. And so another great job by Steve, but how often can we expect that? And can we take the patient off the methimazole before or right after surgery, or right after the RFA, just like we do after surgery? So what do we do here, Steve? What is your typical protocol with these patients? Do you always discontinue the methimazole immediately, or do you wait for that 1 month post RFA thyroid function test analysis?
Yeah, it's a great question. You know, surprisingly, there's not a lot about this in the literature, which I've always thought was interesting. I think in concept, if you're treating a toxic nodule, the kinds of thermal energy that we're delivering is sufficient to destroy the nodule parenchyma, and probably the hormone that is present in that nodule as well. I've heard anecdotally about cases with really hot thyroid nodules where there's some transient thyrotoxicosis, or a transient increase in the thyroid hormone levels. So I think this has to be decided on a case-by-case basis. If you have somebody who's well controlled on methimazole that doesn't have a really high output toxic nodule, it probably is reasonable to stop the methimazole as soon as you can completely ablate the nodule, assuming that your ablation is thorough. In other cases where you're dealing with a very thyrotoxic patient, or the rare instance, Marius Stans has a patient that he treated with Graves' disease. Those may be cases where you want to continue anti-thyroid drugs for some time, but I think it needs to be decided on a case-by-case basis.
Let me just ask the group to consider this. Has there been any discussion about using SSKI first to decrease vascularity, to allow one to have a better chance of achieving the desired result in these situations?
I've never considered it, but I wouldn't want to decrease vascularity. I'd want the nodule to be as vascular as possible, because that would make the target more visible and more accessible. And I don't think the SSKI would, unless it's an unusual circumstance, I don't know that there would be another good reason to prep the patient with SSKI. You would hopefully have them under control with anti-thyroid drugs before the treatment.
Great. Let's move on here and see that at 6 months, the volume reduction is 75%. But so interestingly enough, Steve, already at 1 month, you had a demonstration of a euthyroid patient. And so how much ablation is enough? And do you worry about regrowth in these patients more so than in just your benign nodule patients? I'll leave that for Dr. Baek and Dr. Huber to discuss.
This case seems to be very nice, and it is excellent to achieve normal thyroid function by single session RF ablation. But if the patient shows some regrowing from the margin, maybe second ablation is required.
Do you follow these patients any differently, Dr. Baek, than your patients who have a benign nodule, cytologically non-functional, especially if you think that you've ablated everything? Do you change that follow-up at all?
Do you mean the benign nodule changed to cancer? No,
I'm sorry. Compared to your follow-up for your benign nodule patient that you treat with RFA, do you follow these patients with autonomously functioning nodules any differently because you're worried that they may actually come back with hyperthyroidism quicker and you may need to intervene? You know, do you do thyroid function tests more liberally on them to follow up?
Yeah, yes, thank you. I'm sorry.
No, it's okay. Very early there too, I understand.
It is the follow-up protocol is different in terms of the thyroid function test.
Yes.
Every follow-up we do thyroid function, and if TSH starts to decrease, we plan second ablation.
Excellent. Tim, any thoughts on that? Based on your non-functional benign nodules, when do you measure thyroid functions again, and how, you know, and how often? Are you worried that these patients can become hypothyroid and maybe we're not capturing those? Is it an early phenomenon versus later phenomenon versus the toxic nodules? Just some thoughts on that. I know some colleagues in the United States, while treating larger nodules, may be more concerned that we're seeing more hypothyroidism than we were expecting initially.
Yeah. So for non-functional nodules, we're checking TSH at the first follow-up. And in most cases—
At 1 month? At 1 month out? Yes.
At 1 month, yep. And then we've discussed, you know, how frequently we want to follow after that. And we've sort of settled on, in the absence of any symptoms, hypothyroid symptoms, that we're going to follow up at 1 year. So 1 month and 1 year is kind of where we're going to land for non-functional. For functional nodules, we're following everybody basically with TFTs until they become euthyroid. And then typically one more follow-up past that, just to see if we've overshot, if they become hypothyroid after that, just to see how things go. We kind of want to see a stabilization of their TFTs before we decide to discontinue, and then start spacing out their TFT follow-ups.
Steve, how long should we follow them up with TFTs, these toxic nodule patients?
I agree exactly with what Tim said. So I think that, you know, you want to have some post-treatment follow-up first to make sure that they remain euthyroid, and then to make sure that they don't become hypothyroid. I think what Tim is suggesting is right on target. Ralph, can I just make one other point? I think
please.
Toxic nodules are by definition clonally neoplastic tumors, right? These are,
yes.
You know, this is a single autonomous cell that's divided and formed a neoplasm. There is a higher likelihood that a neoplasm will regrow than a hyperplastic nodule, a truly benign nodule, will have to regrow. And so I think these nodules, these autonomous nodules, probably have a higher risk of regrowth if they're not adequately treated. So it's really important, especially for these, to thoroughly, completely ablate the nodule.
Agree completely. And so you see this summary slide that you nicely provided, looking at a few of these studies, that really the smaller nodules respond best. And those are nodules that are typically less than 25 cc's from a volume standpoint. And so you can see restoration of euthyroidism between 22 to 88%. I guess that's the mean, is 57%. And the Koreans' multi-center data showed TSH normalization in 82% and a volume reduction in 82% of the patients. And again, we have to put all of these options on the table for the patient, for them to be able to make the informed decision as to what's best for them, knowing that they have, you know, 3 options usually, or even including staying on their, you know, medication to have to make this decision. So this has been great. I think the time is coming to an end. Anything that we want to cover that we didn't cover? Any other points of emphasis that anybody wants to make? Dr. Baek, thank you very much for your participation early in the morning, as always. Any final words, Dr. Baek, to leave us with?
It's my great pleasure to join this wonderful conference, and you developed a new society, NASIT. Congratulations.
Well, thank you, Dr. Baek. It's very nascent. We want to be very inclusive. We're still trying to figure out what we are going to do, but we want everybody who has any interest in these interventional techniques to participate, and you will always be an honorary member of whatever we do, for sure.
How to be a member?
Oh, well, it's still very early. We need to work on this, but right now I think Jen will probably talk a little bit about just the website, one little final line, and then we'll let people know a little bit more about becoming a member in the future, but we're not there just yet.
Thank you.
So I think a lot of people are asking what NASIT really is. And NASIT's really just a name that makes it easier for us to, the small group of us that have been starting to do this RFA procedures here and have really kind of come together to share ideas, to learn from each other. It's an easier name to say and give us, but we do want to expand and share and learn with others and make it easier to do so. So we're hoping that this webinar series will give us a forum to do that. And we are planning to do this kind of on a quarterly basis. But those of you who are interested in radiofrequency ablation, want to be part of this expanding group of physicians, multidisciplinary physicians that are doing this here in the United States, please let us know. We have a website that is up and running, www.nasit.org, where you can give us your email address. And as things kind of move forward and we start to have more events and such, we will notify you. And we hope that the website will actually be just a nice sort of centralized resource for all of us who are doing RFA here in the US and in North America. So please check it out.
Thank you all very much. Really enjoyable, and we hope to see you at the next one, which will be, do you have that slide, Jen?
Oh, yeah.
June 3rd, Advanced Techniques in Thyroid Nodule RFA. So I hope you join us for that. We'd love to have you and see more and more. Please tell your friends and anybody interested in interventional techniques like these. Thank you. Good night.
Thank you. Bye-bye.
Bye.
Bye.